Hey everyone, thanks for joining me over your lunchtime. I'm Dr. Jessica McLaughlin. I'm a physician here at Coastal Fertility. And today is one of our lunchtime talks where we get a little extra time to dive into some specific topics. And today I'm so happy to be talking about a topic that's near and dear to my heart, endometriosis. Actually, March is Endometriosis Awareness Month, so I think it's a great time to talk about it. I love taking care of patients, but I think part of taking care of patients and something that's equally important is really the education component. And so I love these extra little, kind of 15-minute talks where I can kind of take a deep dive into some topics that are important to us, important to our patients, and allow you guys to kind of have this as a reference, but also kind of ask some questions, kind of along the way. And so, being Endometriosis Awareness Month, like what is endometriosis? Endometriosis is a condition where the endometrial tissue, think about the tissue that's inside the uterus, and that is what, sheds and you have a period. And it's where that tissue actually kind of grows in other places. That can be in the abdominal cavity, that could be stuck on an ovary or a fallopian tube, but endometriosis is normal endometrial tissue, so what we call gland and stroma, that's what's making up the lining of the uterus, but it's in an abnormal location, so again, out in the abdomen, in a spot where the endometrial tissue, otherwise wouldn't be. The question is, well, gosh, how does it get there? And there's a couple of theories about that. The most common is something called retrograde menstruation. So when a woman menstruates, we have, kind of blood and fluid and tissue that comes out from below, but it can actually go back through the fallopian tubes and out to the abdomen. And that really sounds, I know, like a crazy thing, but that really happens in 90% of women. And for most women, that's no problem at all. The body just naturally will reabsorb that fluid and tissue. But for a small percentage of women, that tissue will actually stick. Again, that could stick to ovaries, stick to the inside of the abdomen in different locations, and actually implant there. So that's what endometriosis is. It's kind of that normal endometrial tissue in an abnormal location, and it will stick in that area. And this really, they found it almost everywhere in the body. So the most common is within the abdominal kind of cavity through likely that retrograde menstruation. And it can have different appearances. Most of the time it will look like, kind of almost a little, kind of dark purple or red little bleb. Again, it's kind of endometrial tissue, but sometimes it can be clear. Sometimes all you see is kind of the scar tissue that's associated with it. And so, it can have a bunch of different appearances, when we actually see it. So endometriosis affects about 10% of reproductive age women. And so it's a fairly common disease. And they certainly have a higher chance for infertility, and we find it more in our infertility patients. So when we think about just infertile women in general, up to 30 to 50% of infertile women may have a component of endometriosis. So, kind of the next question that patients think of, well, how do I know if I have endometriosis? Well, where we usually start is just thinking about a woman's symptoms. And the most common symptom is painful periods. And so that's a word that we call dysmenorrhea. And so you may have kind of pelvic, abdominal, back pain, during the actual menstrual cycle. And thinking about it, again, that endometrial tissue that's out in the abdomen is having the same reaction that's happened during your menstrual cycle. So it's almost like those little areas, have a tiny little bit of bleeding. They're having an inflammatory reaction too. All of that is why the menstrual cycle is so painful. Depending on the location, so if other spots are kind of within the belly, some women will have pain with intercourse. Some women will have pain when having a bowel movement, or even kind of urination. And so those can be symptoms associated with endometriosis too. Some women, tend to have more vague symptoms. Maybe they're constipated or they're bloated kind of during their menstrual cycle. And then certainly sometimes the presenting symptom is infertility. It's common to have symptoms from endometriosis, but there's also a subset of women that will really be asymptomatic. And so if you're having some of those symptoms, certainly recommend, kind of speaking with your doctor about those. Endometriosis, can certainly affect fertility. And so, how does that happen? It could happen really in a lot of ways. The most obvious way, is through some anatomic distortion. So, we have normal tissue in an abnormal location, and the body's reaction to that is an inflammatory reaction. So this can cause scarring of fallopian tubes. It can cause the fallopian tubes to be fully blocked. When it's blocked at the end, that's a word called hydrosalpinx, a blockage of the fallopian tube at the end. It creates an inflammatory environment in the pelvis that eggs just, don't like. So you ovulate an egg into that abdominal environment, and that's affected by an abnormal inflammatory environment. In a more subtle way, it's possible that, it can cause problems with implantation inside the uterus. I think that's still something that we're kind of learning more about. And it can, potentially, affect egg and embryo quality. And so there can be potentially an inherent quality about the egg in women that have endometriosis that's a little bit different. I think, some of those things, honestly, in the medical field, we're still, learning more about. I think about, a fertility or fecundity. Fecundity is meaning the chance that you could get pregnant, that month. And I think about that for, an otherwise normal couple versus, someone that has endometriosis. So when we think about, let's take the couple under 35, normal fertility, trying for pregnancy, their fecundity rate, or the chance that they could get pregnant that month, is about 15 to 20%. Where with endometriosis, that could be anywhere from 2 to 10%. So it really can affect, fertility. I always think of a very interesting study that kind of speaks to how this potentially affects the eggs. And it was a study that they did when kind of looking at, egg donors and recipients. And so, in these studies looking, at egg donation, so a woman that had endometriosis got an egg from someone who didn't have endometriosis, and they noted kind of normal implantation and pregnancy rates versus a woman, that had endometriosis as the donor. When those donor eggs were kind of used into a recipient, the pregnancy rate was a little bit lower. So it speaks to there being something about, affecting kind of egg quality. But again, something we're still learning more about to understand the exact mechanisms. I think it is most certainly obvious when we have distorted anatomy from endometriosis, but the summary is just potentially there's harder things to measure, the inflammatory environment, the quality upon eggs that endometriosis, can also affect. Importantly, endometriosis is a surgical diagnosis. So I often suspect it for my patients, when they're kind of telling me about their really painful periods that they've had their whole life. So certainly have a high clinical suspicion in that scenario, but it is a surgical diagnosis. There are, in addition to clinical symptoms, there are a couple of tests that, give me kind of more information. So when an endometriosis forms in the ovary, that's a word called endometrioma. It does have a very characteristic appearance on an ultrasound, kind of the classic ground glass appearance. It has a certain color of gray that we see on ultrasound. So when I'm seeing that on ultrasound, I have a very high clinical suspicion for what's called an endometrioma or an endometriosis cyst. When I do a test to see if the tubes are blocked, an HSG, that's a special x-ray test where I can put a little catheter below while there's an x-ray test, over the belly, and we look at the screen together. I can put some dye from below, see the uterus, but also see the tubes. And so when I have, big blocked tubes on that test, plus, kind of clinical symptoms that are concerning for endometriosis, also heightens my, concern for endometriosis. very rarely could you see like implants or endometriosis on such things like an MRI. So, unless, we really see an endometriosis cyst or blocked fallopian tubes, a lot of the other time it is, a clinical suspicion, but certainly has to be surgically confirmed. That is really a histologic diagnosis where, to actually confirm it, you have to, biopsy that little piece of tissue, and send it off, kind of for pathology. So the treatment of endometriosis, is really, kind of two different pathways. But the treatment of endometriosis, it is a hormonally active, because again, it's the tissue on the inside of the uterus, is really for suppression. So, this is really in women who are not trying to get pregnant. So if you're not trying to get pregnant and have endometriosis, really the treatment is to suppress the hormones. And so there's different ways to do that, but that could be a birth control pill. There's medicines called Lupron that will kind of temporarily, kind of shut down the ovaries in a sort of menopausal state that, so you don't have a period and kind of those hormones are shut off, or Lissa is another medicine that does a similar thing. And so all of those, would be the mainstay of treatment, suppressing hormones, but really, not in women that are trying to get pregnant. So for fertility, medical treatment, to improve fertility, really is only going to, result in a delay, and is intentionally kind of trying to suppress those hormones. So medical treatment, is not a great treatment in women who are trying to get pregnant. So the next kind of question is, well, should we do surgery? Surgery is really something we think about for women, if they are having other symptoms, kind of from their endometriosis. So, surgery works well for patients that, maybe they tried medical management, it didn't work, and so they moved to surgical management for endometriosis to take out some of the endometriosis, and that really does help from a pain standpoint. So that may improve their pelvic pain, that may improve, pain with intercourse or pain with menstrual cycle. But surgery, this is a general statement, but generally not recommended just for the sole indication, of fertility. And so I think this is, honestly something that has changed over years and years and years. It used to be that all women would end up with a laparoscopy just to kind of check the inside of their abdomen. And thankfully we don't do that anymore. And the reason is, the therapeutic benefit of doing just a laparoscopy to increase, that fecundity or fertility in women with kind of mild disease or otherwise asymptomatic, and just doing it to check is very minimal. And so, we no longer do a laparoscopy just to kind of figure out if a woman does or does not have endometriosis because, of the, kind of minimal, if any, improvement, and we wouldn't put a woman through a surgery. Just the risk-benefit ratio is not there. I think in general surgery, there's always pros and cons. So, of course, surgical risk, but it can, cause scar tissue that can affect fertility. When we're operating on the ovaries, we can remove, kind of normal eggs and normal ovarian tissue that, hurt a woman's ovarian reserve. And it really doesn't improve significantly kind of pregnancy rates, and potentially has, kind of some downsides. But very importantly, I think that's on a case-to-case, basis. And so, there are still potentially reasons you would do a surgery. An example being, if a woman had a cyst on an ultrasound, but maybe it was an unclear cyst, maybe it's not that classic endometrioma, maybe it's growing and all of a sudden we're having pain symptoms, or we're not sure it's an endometrioma, could it be something else? So there certainly are still times, and your doctor will work with you to kind of tell you if they think kind of surgery is an appropriate thing to be thinking about. But the summary is that, off the bat, it is, not the usual first step just from a pure fertility standpoint. Sometimes there are other reasons. medicines that we're kind of needing, to think about surgery. The question is, can we get pregnant with endometriosis? The answer is yes. Natural fertility, is lower than someone that doesn't have endometriosis. So again, it does affect that baseline fecundity rate or baseline fertility. What could we potentially do about it? So let's talk, could we do like a simple fertility treatment? So our simple fertility treatment is called an IUI cycle. It's where we stimulate the ovaries, called ovarian stimulation, and combine it with getting the best sperm there at the right time, or an IUI. It takes sperm, wash and concentrate, and put that up to the top of the uterus. And so I think an IUI cycle, let's say we did our whole evaluation. We looked at the ovaries, we looked at the tubes, we looked at the sperm. We think an IUI is an option. If the tubes are open and the only component we know about is endometriosis. So I think an IUI can still increase us from baseline. Again, baseline's not, kind of not zero, but if we compared an IUI success rate to someone without endometriosis, it's probably lower. So, the estimates we give are always going to be plus or minus, but let's just take an example. Let's take, a couple under 35, that, has endometriosis. What's the chance they're going to conceive on their own, when they have a diagnosis of infertility? Could it be 2% per month? If we, add in an IUI, could we otherwise get a 10% chance per try or something like that? Whereas potentially a woman under 35 with unexplained infertility, maybe IUI success rate could be 15 to 20%. So I think it still is potentially an option. I think it still increases us kind of from baseline, but it is potentially lower than someone without that diagnosis. So I think, again, something your physician would talk to you about, on a case-to-case basis, if IUI, is a good option, kind of for you. When we do an IUI, we are going to ovulate that egg into the endometriosis. So the egg is being exposed to that, inflammatory environment. Maybe if the tube's open on HSG, it looks open, but is it functioning normally with the endometriosis? I think potentially those could be some of the reasons why an IUI success rate is a little bit lower, but, kind of still an option. So what would be another option besides, IUI? Well, IVF is going to be the option that really bypasses the abdomen. We're going to bypass the endometriosis environment. And so, a summary of IVF is that we give medicines to grow the eggs. We do a procedure to get the eggs directly from the ovary. We combine egg together with sperm in the lab. We grow out the embryos. They're frozen. And then in a future cycle, I'm going to thaw an embryo. I'm going to put an embryo kind of directly in the uterus. So that, of course, is a very brief overview. But in summary, we didn't expose, that egg, at all to kind of the endometriosis. So it really does, avoid the abdomen in that way. Certainly avoids the fallopian tubes, if that's also, a concern. So I think, IVF is probably going to be our highest success rate with endometriosis just because it's able to avoid those factors. Still, I think something to know for patients is that the egg quality with endometriosis can potentially be affected. So if we were to compare two patient populations, maybe someone that was doing IVF for, a different reason, maybe a tubal factor that didn't have to do with endometriosis or a male factor, could the endometriosis IVF success rate be a little bit lower? Yes. But still IVF success rates are overall high, and specific for this patient population, the best way to kind of optimize that fecundity, again, the ability to kind of get pregnant. Another question I often get, and honestly another scenario I see very frequently, is what if we have that endometriosis cyst in the ovary? What should we do? Should we go take it out before we do IVF? Should I try to work around it? And this, again, is something that's kind of changed in our field. So unless a patient is very symptomatic, maybe it's growing, maybe, we're not clear about the diagnosis, if there's otherwise an overall small kind of area of endometriosis and a woman's not having a lot of symptoms, I think the risks of a surgery outweigh the benefit, and we would do IVF really just around that area of endometriosis. So let's say there's endometriosis kind of right in the middle. I'm going to get the eggs to grow all around it, and we'll just work around kind of that endometriosis. So again, something that's kind of changed in our field, but a lot of time if you do have an endometrioma or an endometriosis cyst in the ovary, a lot of times we're doing IVF, just, working around, that area. The last thing I wanted to briefly touch upon, is just really kind of something that it is an idea and a thought. I think certainly endometriosis can, kind of affect fertility. And so, in women who are, have endometriosis, potentially, desiring to delay childbearing, I think fertility preservation is a very reasonable option. The ability to kind of preserve eggs or preserve embryos, especially if someone's kind of not, planning on pursuing, pregnancy until kind of later in life. The other thing, if you have endometriosis, it again is not impossible for you to get pregnant on your own, but it's certainly not a scenario where I wouldn't, try forever. So if you have endometriosis and you're not pregnant kind of at the 6-month mark or something like that, of course that's always going to be age dependent on what that number is, but meaning that, I would seek, evaluation and help kind of sooner rather than later, because we just know that endometriosis can affect fertility. So, in summary, endometriosis is common. This is a very common, disease process that we're seeing within our infertility, population. I think if you're having symptoms, don't wait too long to get evaluated. We want to help you kind of figure out what's going on. It can worsen over time, and it can, affect fertility, but fertility treatment does help, and, still, something like IVF, again, the pregnancy rates just because of the different, mechanisms that, are associated with endometriosis, can be slightly different than other diagnoses with IVF. But the summary is the IVF success rates are still high. It's still going to be a great option to help you achieve pregnancy. So we'd love to kind of continue that conversation with you. I hope that was helpful. I think we may have a couple of questions. Yes. Is that right? So I'm happy to get to those.
Okay. Madison says she just had endometriosis surgery last week because she has struggled with unexplained infertility for over 3 years. They have tried multiple IUIs as well as IVF, both which were unsuccessful. We figured that this would be a good last option to try and increase my chances. They did end up finding it on and around both of her ovaries. So she was encouraged that the surgery would be worth it. Do you expect she will be able to get pregnant now that she's cleaned out? And she also added one more question. Would you recommend we try naturally after this, or just jump straight to an IUI?
Yeah, no, so that's a great question. Thank you, Madison, for that question. I'm sorry for everything you guys have been through so far. I think with kind of after a surgery, honestly, that's a very individual question, understanding kind of where your ovaries are, kind of things about ovarian reserve, overall egg, quantity and quality. I would be, kind of proactive. So again, I think, nothing's black and white, but if you do want to try on your own, maybe you give that month, a 3-month time frame or kind of something like that. So again, that's not set in stone. It's, reasonable to potentially try on your own. But, just because, studies have shown not a huge increase, in fertility kind of after, just from a surgery standpoint. Again, for you, that, I think that's a reasonable thing. And I'm sure, there's kind of more backstory to it. But, if we wanted to try on our own, whatever that time frame is, something around a 3-month time frame, I think is reasonable before, kind of thinking about getting into some treatment.
Yeah, I think that's it.
Okay. Yeah. Well, thank you so much for joining me again. Save this and you can kind of watch that later as you're kind of thinking of potentially if this comes up as, something that you wanted to kind of learn more about. We will continue these. I think they're great education, kind of sessions for our patients and honestly staff and everyone. So we really enjoy doing them. And so we'll talk to you guys soon. Take care.